Good afternoon, everyone. I'm Michael Klontz. I'm the Chief Operating Officer of the Guild for Human Services. I want to thank all the folks who have registered for this webinar panel for joining us and spending the next hour with this great group of panelists. Really excited to have conversation today. My job is to welcome everyone, talk a little bit about what we're working to achieve today, and then offer some questions for our panelists. So hopefully all of you have had an opportunity to see the documentary focusing on AAC use in the community. We Need to Talk is a 14-minute film, but the conversation it starts needs to be much longer. Tonight, we're going to try and go deeper and talk more about AAC use in the community, access, transition to adulthood, and thinking about AAC communication in different settings. You're going to hear from a speech language pathologist who spent 30 years in the field, a mother who's navigated systems to ensure her daughter can communicate, and a physician who sees AAC through both medical and a deeply personal lens. These are folks who live in this reality every day, and I'm really excited to hear from them. I'm going to give them each a moment to kind of introduce themselves. I'm going to start with Mary Giunta.
Hi, everyone. Good evening. I'm Mary Giunta. I'm a speech pathologist and AAC consultant. I work for EdTech Solutions. We're in over 60 different school districts in the Boston area. My role is to complete AAC, school-based AAC evaluations, trainings, professional development, implementation, and coaching. Thanks for joining.
Thanks. And we have Oanh Bui.
Yeah, hello everybody. Thank you for being here. My name is Oanh Bui. I'm a proud mother of Tiny, a bilingual AAC communicator, and I'm also a Vietnamese cultural broker. I founded the Circle of Vietnamese Parents, a community that offering educational and emotional support for Vietnamese families of kids and youth with disability and autism. I'm also a passionate advocate for communication rights for adults with autism and adults with disability. Thank you for having me.
And Michael.
Good evening, everyone. My name is Michael Tarr. I'm an emergency room physician and the associate director at the emergency room at Lawrence Hospital, part of the Merrimack Health Care System in northern Massachusetts. And I've been an advocate for patients with intellectual disabilities and communication barriers throughout my schooling and training. And early on as well, with my experience with my sister Caitlin, who was featured in the Guild's film, who's been using various communication devices throughout her life.
Great. Well, thank you all so much. We're going to kind of get into some questions. I've prepared some questions. I've tried to incorporate questions from folks who offered up those in the registration for the webinar. What I will say is we may not get to every question today, and if folks want to chat questions during this session, that's great. Nicole, who is behind the scenes and kind of hosting the webinar, will be able to review those, and if there are some that she can push forward to us, then we'll try to tackle those as well. Any questions that we're not able to answer today, we will certainly follow up and try to gather any more information or resources that folks need. So again, thanks so much. We're going to start talking a little bit about kind of communication journeys and getting started. And again, looking at different perspectives. I want to hear you talk a little bit about the process of getting AAC supports for Tiny. And tell us a little bit about that journey.
Yeah, thank you so much, Michael. Accessing AAC for my daughter is quite a long road, but it's so worth it. I still remember very early on, I sit and I have to sitting in the school parking lot crying because my daughter has just had a meltdown and I have no idea what she needed. She has no means of communicating. When she first came to the US, she has no words, just behaviors, just tantrums. Back then, the school taught her signs, which she picked up very quickly. However, she has low muscle tone, so her sign is not universal. Not everybody can understand her sign. So every time she go out, she have to carry an album with a photo of all her signs and its meaning to be sure that people don't miscommunicate or misunderstand her. Right. So after that, we move into PECS, Pictures Exchange Communication System. Then the book got too big. That's when I started asking myself questions regarding what next for her. And thankfully, back then, I found Istacil on my own. I got tons of long device and tried it out, help myself, teaching myself, working with Tiny and teaching her because back in the day, I can't wait, right? Then came into the IEP meeting. I had to sit across the table and prove with all documentation that I could, with all the videos that I made with Tiny, sometimes with tears, trying to advocate that my daughter really need this tool so that she can communicate, she can access the curriculum, she can be part of the school setting. But when we finally got a device, I was told that it was for school use only. What that means that every morning, every evening, every weekend, every holiday, she would have no voice. I did push back because it's my choice right. Communication is all day long. It doesn't stop at 3 p.m., the time that she get home, right? So as if the IEP battles were not enough, I remember the speech pathologist told me to stop speaking Vietnamese at home. Let's sit with that for a moment. Vietnamese is my native language. Vietnamese is my conscious. It's how I communicate with my daughter. And again, I'm glad that I did not stop speaking Vietnamese because now she could understand, she can communicate with my mom back in Vietnam in Vietnamese.
Mm.
Eventually, she got her old Dynavox, and that's when things really opened up. Every morning, she communicate with me, asking me to twist her animal balloon because that she loved. And I use her strength space to teach her language development. First, just the animal, then adding the adjective, then she commenting. And for sure, some days she's like, Mom, this is not look good, right? But I love it because she's communicating with me, right? So if you are a parent who just starting out, there are three things that I'd like to share here. First, do not wait. Don't wait for the school to bring it up. You can request the AAC evaluation for your child anytime. And don't be afraid that your child will never develop speech if they use AAC. Having access to AAC early will expand your child language development and speech for sure. Second, model every day. Use your device with your child in real life, in any communication during mealtime, during your reading times, during your book time, anytime. Communicating it beyond request, right? Just don't stop at the request. Use that. The more you modeling, the better your child will develop language. And third, just don't go alone. Find some parents who walked the journey before you. Find any AAC specialist and do ask questions. Remind yourself that it is okay for pushing this hard for your child's voice. It's worth it, right? AAC is access to language, access to speech, access to connections, and also to dignity. And your child and our children deserve to be heard. Thank you.
Thanks. That's really appreciate that story and kind of telling us about your journey. Mary, I saw you shaking your head and I saw some hearts popping up, but I wanted there's two well, I'd
I
love to
was
hear your comments because I think
I
there are a
was
couple
sending you
things.
love on. I was
Yeah.
sending you love. If I can bottle up and take that and just play back what you said to every parent, I'm yes, please. Or we're hiring at EdTech, by the way. No, I'm kidding. No, not kidding. I mean, thank you. Thank you for persevering and thank you for bringing up those points. I think that is a message we need to convey. Thank you.
Yeah.
Thank you.
Two things that I saw that you mentioned. One was the concept of an AAC device being for one setting only, so school. And Mary, I saw you kind of shaking your head to that as well. Like, from your perspective, how is that something common that folks may hear? And how do you, you looked like you were going to push against that sort of for professionals. Tell us more about your thoughts on that.
I know you hit a sore spot on me. Under IDEA, schools must provide AAC as part of free appropriate public education. And as long as the IEP team agrees that communication happens outside of school, and it does, then the device needs to go home.
Great. I appreciate that and that clarity. Another piece that came up was, and on you talked about the challenge between education in English and also speaking a different language, Vietnamese at home. Um, Mary, kind of, how do you help from a professional perspective? Again, I think I know what you'll say. How do you help families who are multilingual to kind of navigate this from your perspective?
I always try to match the a home language. If the device contains the home language, if there is a software that supports the home language, then yes, our students are bilingual, are trilingual, and they have the right to speak every language in their house.
Now, on when you talked about, if you could say again, what was the name of the device that when Tiny kind of received that just kind of opened up a lot of capacity? What was the name of that device?
Yeah, her first device is the Dynavox, and it's very big, heavy, bulky. It takes a lot of effort to be able to program it. But now we transition to the iPad with the touch chat. So yeah,
Oh, great. Okay. So, and then eventually that transitioned into the iPad. Okay.
right. Yeah, got a hand through Istacil so many different devices that I could to be able to try it out with her at home. So yeah.
Great. Can you tell us a little bit about that? You were talking about kind of communication with your mother and folks at your home in Vietnam. Tell us a little bit about how you navigate that on the iPad or with AAC.
So with her, because the fact that I don't stop speak Vietnamese to her, she understand Vietnamese. So we
Mm,
could be able to communicate. My grandma talked to her in Vietnamese. She understand and able to respond in English. So I would have to be able to translate so that my mom can be able to do that. We just started to try out the application in Vietnamese so that
mm,
she can be able to directly communicate with her in Vietnamese without me to translate. Like she can understand receptively, easily. Very early on, when we first try it out, she has the capacity of really change and spell phonetically some of the Vietnamese, attempting that she would communicate using her AAC in Vietnamese. But it takes a lot of effort to do that. Like we trying to do that, but it took so much time to program Vietnamese phonetically. So we stopped doing that and trying to continue to verbally speak in Vietnamese. She responds in English, but then we keep that bilingualism at home as much as we could to be able to maintain our native language. So yeah.
awesome.
Mhm.
Yes, Mary.
I'm so excited. I just can't stop myself. So the new, so many apps are now have a built-in AI feature that translates to other languages. And I'm not sure. It looked like your daughter's using Touch Chat.
Right.
Was that correct? Yeah, they have a new feature now and I'm
Ah,
99.9% sure it supports Vietnamese. It just has to
ah,
be a certain kind of app. We'll talk later,
we
Colin.
talk.
All right.
Definitely.
Okay.
Awesome.
Definitely.
Great. Thank you. Kind of continuing on that theme of sort of communication journeys, before you were Dr. Tar, Michael, you were just brother Michael, um, and you lived with Caitlin and you communicated with Caitlin. And I wanted to hear a little bit about how you bridge your personal experience, sort of with your own medical training, but also in your current setting.
Yeah, for sure. Thank you for that. Um, So I think first and foremost, it gives me empathy for these patients, patients across the spectrum of communication difficulties and barriers, including those with developmental disabilities and those who have acquired disabilities through things like traumatic brain injury and stroke. And in the emergency room, certainly a trauma center, first and foremost, our priorities are to stabilize a patient. And those first few minutes can be very scary for any patient, certainly, but for those that have barriers to communication and also maybe cognitive disabilities or perceptive disabilities can be really hard on them in particular. And so, really understanding that I have, through my training, I've lectured medical students and I've lectured residents on really how to approach patients that have developmental disabilities when they're in a crisis type scenario, for instance, a trauma or they're very ill. And a lot of this can relate to my sister, really trying to make the environment as natural as possible, which is obviously very difficult. Bright place, there's a new 10 people around you poking you with sharp things. Um, and like I said, priorities obviously is stabilization, but as soon as we can confirm that like any life-threatening processes have been managed, immediately we want to find out how to communicate with this patient. Is this a patient with hearing aids? Do they have their hearing aids? Do they have glasses? An AAC is similar to a prosthetic limb, to glasses, to these augmentative devices that are really important for us understanding what is happening and what this patient's going through and how we can best care for them. And so some of my you know, growing up with Caitlin, anyone who has grown up with or raised a child or a sibling who has, intellectual developmental disabilities, you learn patience and you learn that some of these processes can take time and can be frustrating at times. And so, one of the first things I tell the residents and the young doctors and the student doctors is this is going to be a difficult interaction for you as well. And you need to count to 10 and you need to take a deep breath and go slow and give the patient time to communicate with you because what they're saying is obviously very important. Um, this is somewhat related. If any of you have watched the show on HBO, The Pit, I highly recommend it. It's actually one of the most accurate depictions of my job and what we do. But there is a scene where a patient um, it does not speak English and they're using an iPad to communicate with an interpreter and they're having difficulties. And man, does that connect to me because that is so common. And the young doctor becomes frustrated and decides just to overtest and get a CAT scan and go through with this. And then later learns, I need one of the senior doctors took them aside and said, that's not appropriate, right? This is a person. You need to treat them as a person. And just because it might make your job a little more difficult or take a little bit more time, you're here to treat that person, right? And so that communication device, that translation service, this ties immediately in with an AAC device, right? That is their voice. And going off of what Owen was saying, And Mary was saying those devices need to come home and they should go to the ER and they should go to your doctor's offices, because how do we communicate with them, right? Otherwise, we're in the dark and they can't tell me what's going on. They can't tell me what's hurting, or I can't know what their baseline is. And so going slow, using their device as their voice, taking your time, being patient, and talking to the patient. I think those are really some of the big takeaways that growing up with Caitlin and then transitioning to medicine, there are things I've learned.
Thank you. Mary, thinking about kind of these communication journeys, and you've talked some about this through this process, but I also want you to kind of walk us through from the AAC evaluation process. And Owen gave her perspective as a parent, and kind of building off of that, talk to us a little bit about from that referral to getting access to AAC, and kind of incorporate what tips you have for success.
Okay. Dr. Tarr, I loved your analogy of AAC should be like glasses are a hearing aid. That's a great analogy. I'm going to borrow that now. I'll credit you though. Okay. So you're interested in obtaining an AAC tool for your individual. Your first step is to talk to your team because you will need a referral. You can go a couple of different routes. You need a referral to a speech pathologist who specializes in AAC. And we speech pathologists, right? We work in clinics, our hospitals, our private practitioners, or a school. So get your referral, talk to your team, get your referral to a speech pathologist. Remember, you can go through the schools because it is part of free appropriate public education. Consider your funding options. This is something that you need to have in the back of your head as you're going through this process, because the funding options are going to look differently. If you go through the school, it will be provided as under FAPE through the school. Easy funding option for right now, right? You can also go through medical insurance. The benefit, you own it. It's always yours. It will never have to go back in the summer or on weekends. You can also privately pay if you are going to secure an iPad with a communication app. You can always ask for, there are grants that you can write a grant and also achieve a device that way. But let's do an evaluation because you might not know what your child needs. So you're going to get your evaluation from the speech pathologist. You'll have already determined what you think your funding avenue will be. Here's a tip. If you are going to go through medical insurance, you want to talk to your medical insurance and ask what your benefits for a speech generating device are and the code that you're going to ask. The code is E2510. E2510. That's the code that you're going to need. Okay, so then the evaluation happens. And what happens during that? There should be feature matching, which means that we take a look at the person's access method and vision and other languages that they might speak and their current communication profile, the AAC user's preferences. There's no single factor that decides it. I don't select tools based on my favorites. I don't have a favorite. We do the feature matching so that the tool that the student or person gets is the tool that matches their needs, their particular needs. During the evaluation, there should be a trial of a couple of different tools. Next comes the report writing and recommendations. If you are going for a medically funded device, you will very likely have to do a trial, a 30-day trial. And in that 30-day trial, you will have to take data, that raw data that you're going to have to submit to your insurance company because they're going to want to know how this person is using the device because you are asking for medical funding for it. So you take home data, community data, along with the other data that your team is also taking. Once we have all that, you will send in the evaluation and the trial data and the report and all the other paperwork if you're doing insurance funding. Dr. Tarr, you love insurance stuff, don't you? It's your jam. It's what you do. Okay, all right. So you send in all your paperwork. Once approved by insurance, the device will be delivered. Yay. It very easily can take 3 to 6 months by the time you submit the initial report. It takes a while to get a device medically funded. The thing to remember is once you get that device delivered to your door, that is not the finish line. That's when the work begins.
Okay. Talk to us. So two things. One question that came up. So you talked a little bit about kind of two funding paths. And so for folks who have gone through the through special education funding, what does the process look like when individuals are turning 22 and graduating out of special education funding?
Please make sure if your child is coming up upon the transition period that a device, that an evaluation is secured before they're 22 and you have a plan. So a couple things can happen. Some school districts will allow the family to purchase the iPad that the child was using in school and will allow them to keep it. Other times, that is when a student turns 20, 21, that's when I will conduct insurance-based evaluations to secure the funding. Other option, DDS. Sometimes if you secure your funding and for AT and AAC, DDS DDS or DSS? DDS, right? DDS.
DDS.
Will help you fund a tool as well. So just
Awesome.
as your student is getting older, line these things up.
Yeah, great. So there's the kind of that referral process, funding process, getting the tool, the device, and then, like you said, that's where the work begins. Thinking about that sort of from the perspective of whether it be kind of parents, family members, teachers, support staff, what do they need to know, and what does that work look like?
Is this for me?
Yeah.
Okay. Training is my favorite part of the job. That is what I love to do because we know that communication partner skills predict successful AAC outcomes. It is very important to train the communication partners, everybody on the team. So what it looks like from my lens, remember I'm in the schools. I will train the whole team how to physically operate the device, the organization, why we selected that organization, how to find words, how to do some basic technical troubleshooting. I will explain to the team why the person has an AAC device. Some people have unreliable speech, and people might ask me, well, they talk. Why do we have to use it? So we will explain why the person has the AAC device and that the goal is for independent communication. Sometimes I work with people who have speech, but it's prompt dependent, meaning that they wait to be told what to say and then that they will say it. But we want independent communication. I will train teams, Owen was talking about this, on how to model on the device and how to build authentic communication routines in the school and at home. I talk about honoring multiple modalities and doing a mind shift. It's not, I'm going to make this person use the device. Change it. Think this. Think, I'm going to show this person how to use the device. Focus on the connection, not as a platform for asking WH questions. And, I think that one training is not enough. And people benefit from ongoing coaching and demonstration. Let's all believe and really, really buy into this. The AAC system is worth using.
Thank you. I'm going to jump to On because you talked as well about moving through the advocacy, getting sort of the tools that were going, that were a good fit for Tiny, and then the work that was done at home. And so I wanted you to talk a little bit about that, but you also talked about finding people, finding that network of other folks. And so hearing about training, hearing about practicing, and just maybe talk a little bit about that, what folks should be thinking about as they're perhaps starting their journey.
Yeah, no, definitely. Modeling and using that constantly as if, the device is just seamless to any child or any individual who communicate, right? So for anyone who communicate with AAC, just similarly like that, we continue to communicate as if this is their real voice and just don't let the AAC as the barrier for that. One other thing that I have been teaching Tiny at home is using the strength based and her preference or interest as a way to facilitate and prompt the language development with her. The first example I said is more the animal balloon that she loved, but now she also developed the interest in emoji. So we also use emoji to talk about her day, her movies, her interests. Then lately, she really loved pop toy, right? So anytime we go to the movie, right, we would use that characters that she loved, thinking through the pop toy that she going to obtain, right? Thinking the places that she going to find these pop toy, when she's going to get these pop toy, how can we work toward that to earn money to be able to do that? So I incorporate all of that in, not just for communication, but different skill sets as well, so that she know that just like everybody else, these are the things that we do with her, right? So that what one thing that we do. So as a parent, because sometimes the assumption would be having access to the AAC device, the individual would be automatically communicate. It doesn't work that way, right? A lot of training, a lot of modeling, and the whole interdisciplinary team need to be trained on that. And the thing that I'm seeing lacking currently is the training to the parents so that parents know how to model using this AAC device with their kids at home. Sometimes for parents, we always think that, oh, I understand my child. I don't need to model using the communication device. But if we don't continue doing that at home and in every setting, it might not really helpful for the child to be able to understand this is the way that we can communicate, right? That multimodal way of communication. But if this could be the main way, especially for Tiny, I continue to use that as much as I can and modeling that with her. Consistency is key for sure.
I really appreciate that point, kind of thinking about there may be a lot of team-based training, maybe at a school educational setting, and then that support for parents as well. Um, Michael, you have talked some about this, but you know, how do you help medical professionals or folks kind of in and out of, again, I love the pit, so I'm envisioning that, but like a hectic environment where already there's challenges to communication. How do you help folks kind of, engage in different ways to communicate?
Sure. So a lot of our approaches to patients in the emergency room rely on first how they appear and how sick they are and what they're coming in with, and that kind of dictates how we act at first, how aggressively we are with our care in terms of like, are they crashing right now, like in the pit, right? Or is this something we have a little bit more time and we can really take a step back and say, is this something that's like been developing over days, weeks, what have you? And at that point, really, let's look at the data, right? Who's with the patient? How does the patient communicate? I'm going to talk directly to the patient. Certainly one of the things I teach is, for instance, patients with cerebral palsy, many times they may appear to have greater communication disabilities and receptive language than they actually do, and may have absolutely no intellectual or communication disabilities, what have you. And so, looking at the patient, talking with them, seeing are they coming from a group home setting? What kind of paperwork are they coming with? Are they with a staff member that's and this is and this is another hurdle. Very often, it's almost the rule, not the exception, that you're with a staff member who this is their first day. And you're like, oh no. So they don't know the patient, but you really hope, like, how well, you ask the person, how well do you know this patient? What do they normally look like, right? What um, I'm looking at them, I'm looking at this behavior. Is this normal? I don't know. I'm relying on you. I'm relying on the patient. I'm relying on the people around them, and I'm relying on the data you give me because I'm completely in the dark. And so, um, it's a very humbling experience when you encounter situations and patients that have kind of these barriers where we're working together and we're just like, we have a mystery, we have to solve it. Let's work together. What data do you have? What can we all put together? In the meantime, how can I reduce your suffering and reduce pain? One thing I, really urge when I'm teaching about approaching patients with IDD is that we undertreat pain, and often they don't express it in the same way other patients do. And so, if you're a parent or an advocate out there, I would definitely uh, reiterate that, or at least state that when you're with your person you're advocating for or family member, saying, um, they may not look like it, but I think they're in pain. This is how their pain looks to me. I ask them, what does it look like when they're in pain, right? Because that's going to, a lot of times their behaviors are extinguished by feedback from medical field or community throughout their life. And so they're not going to shout out. They're going to kind of be, these patients might be more stoic. And so taking all those things into consideration, that's generally how I reflect on the emergency room doctors I talk to and teach. And then in terms of primary care, for a while I've been working on projects and different, basically we call like a passport, where we're trying to get primary care doctors to have the patients and the people come with forms. It tells us kind of like all about them, and it helps the emergency doctors probably more than anyone because we don't know them at all. And it gives us a rundown of what is the norm for them. What do they walk with a cane? Do they need a walker? What kind of communication device do they use? What's going to happen when I try to draw their blood? Am I going to get a really bad, physical response from them? Are they overstimulated by lights and sounds? If anyone's interested, I've been working on this with my hospital. I have a great form. It's in English and Spanish. I can link it. I have no ownership to it. Anyone, you can print it out, fill it out, bring it to your person's doctor and say, hey, can you put this in their file? Or, but all the medical systems are different and difficult. You have Epic and Meditech and all the different electronic medical records. And so, unfortunately, there's no one size fits all, but the goal is for us all in the medical field to share as much communication and data as we can. So when I see the patient, I can get all that information as soon as possible and then shift my focus to the patient.
Thank you. And you've kind of touched on this, but one of the questions from the audience was, describing what kind of training medical professionals get around either AAC strategies and you mentioned several folks with cerebral palsy, but kind of special populations. What does that look like now? And do you think it's enough? Do you think there should, what should it look like?
I was, um, I am still a young doctor, but I am a bit far out of medical school. But when I was in medical school, 2014, it was very lacking. I mean, we had a genetics lecture. It was on, genetically predisposed, it would like hereditary and genetic abnormalities and disorders and diseases, and you kind of read it in a textbook. And then we had our standardized patients, but they would never they were never had like cognitive disabilities or intellectual disabilities. And so, I mean, working with my sister, growing up with my sister, I became very involved with an organization called the American Academy of Developmental Medicine and Dentistry and brought a chapter to our medical school. And the whole goal was really to try to improve education. But I mean, the requirements for medical education are very low. I mean, maybe 1 to 2 lectures in the entirety of your 4 years of medical school. And then you're in a residency and you are interacting with this community and this population, and you have very little training in this. And so you either have to teach yourself or learn on your own, or you just do a bad job at it. And I'm sure any of you here who have interacted with the medical community, you know that the experience is wide and varying, and you sometimes have very negative experiences. And so, um, you know, I've done very little, but what I can in trying to raise awareness in education, but there's definitely still a pretty significant gap there, unfortunately.
Hmm. Well, I mean, thank you for that. Thank you also for the idea for the, I love the idea of the sort of the passport, and something that can be, really specific to that person being served. Thank you for sharing sharing that link, kind of tying that in to Own and to Mary. So Own, from your perspective as an advocate, both for Tiny as an advocate for others, thinking about other ways if that training isn't always like embedded, how do you as a parent, as an advocate, as a someone who's going to the primary care ER, using AAC, how do you help provide that in the moment training and support?
Um, a couple of times that I just pause, I just let that providers figure it out how they can communicate with my daughter right in the room. Because if I'm not there, I don't know what going on there, then I could not be able to help my daughter either. So I did let a couple of times that they have to figure it out. So they could figure it out because Tiny could be able to express like what she needs there. It definitely take longer time in the moment because the providers also find different ways to prompt first,
Mm,
and the provider also require some time to wait for her to process.
yes.
So a few times that's what I'm doing. Basically, I'm just saying nothing and just let them figure it out, and they figure it out. So it will take time for sure. But if we can, I mean, as a parent, sometimes it's hard, but sometimes I might have to step out and let that real life experience for the providers, then they could be able to understand better.
I love that. That just that stepping back and letting that happen, and knowing your daughter, trusting her fierce self-advocacy as well, that she will also, make sure that folks are listening to her, which I think is great. Mary, you spend a lot of time, in schools working with families, either in your experience or kind of in that SLP world. How much interface is there with, say, medical providers in terms of like training and providing resources?
Uh, I will help families, especially if we know that there is an upcoming medical surgery event procedure. I will help families create communication passports. It's a really nice thing to do. Not only do I think it helps bring awareness for the medical providers, but sometimes people don't know what to talk about. And knowing on a communication passport, which would have, this is how I communicate, this is what you need to know about me, this is what I'm afraid of, these are my sensory needs. Um, it's nice to know that they like Disney, somebody likes Disney princesses or whatever their particular interest is, because when I don't know somebody, I ask questions. And if the person is under distress, or at that time in pain and cannot communicate, it's nice to have the provider have access to the communication passport and then talk to the person about things that they like to talk about. I think it brings everybody's stress level down. I think it will help the person who uses AAC bring stress level down. And I think also for the medical provider, because now you know what you can talk about with that person. I love I'm wondering, Dr. Tarr, if there could be like as part of the onboarding process, if you're not getting the training in medical school, could it be part of the onboarding process in a
Sure.
hospital? And we don't make the
So
rules. I know.
I would love for that to be. Hospitals, unfortunately, they generally function as corporations, and so my honest opinion is I believe that similar to when, I don't know, the 70s or so, and there were significant barriers to people with disabilities, I think you need like widespread, broad sweeping political action like the American Disabilities Act, things like that, to really force organizations to require certain um, devices and accessibility. I mean, I work with incredible people and they're very passionate and they're compassionate to our patients as well. And so they'll do the best they can. But with the limitation of the education and the training, I think has to start with the medical organizations and some of the medical organization specialists, certainly like neurology, and they work with an epileptology, and then um, geneticists and what have you, just advocating and developmental specialists as well, just like really advocating for um, these aspects of education to be ingrained both in medical school and in training, I think is what's going to make the biggest change. But also, unfortunately, those are the most difficult changes to tackle in terms of onboarding process. I would onboard a lot of doctors the and nurses as well, and the majority of it is just learning kind of like what the flow and the protocols are at your site. And so ongoing education is important, and I think and that's something I do with my staff and with the nurses I work with. And so in the smaller communities and hospitals, I think you just at this point you rely on people that are in the know and relate to this community and can kind of share this knowledge and their experiences. I don't mean to paint medicine as so grim, by the way.
Well, I think
We're trying.
well, I from seeing an organization that you know works with a lot of folks who are accessing medical facilities in the community and also use AAC. It also thinks of a great opportunity for us to think about how we're whether those be tools like that patient communication passport, but kind of those education pieces as well, and using our organizational power as well to kind of push that. So I appreciate that.
It's getting better. I will say that. Not as fast as
Yeah.
some of us would like, but at least in my experience, it's awareness and interactions have certainly improved over my life and my medical career.
Well, one theme that I'm picking up on, which I really like, is sort of that being proactive. And so, if you're just in any situation, if you are going into a situation where you may think that folks are not going to quickly understand what you may be going through, that idea of like kind of pain baseline, how you communicate, sort of preferences, just in that place when you're not in crisis, I think is a really great helpful tool for many folks, and in particular folks who are going to be arriving at a place where folks around them may not know how to necessarily navigate communication as fluently. I'm going to kind of shift gears here. We've talked some about the process of kind of training providers, educators, parents, talked about medical facilities. In the film, we see you and Tiny at a restaurant, banh mi oi, very delicious banh mi's in Waltham, Massachusetts. For anyone who's nearby, I of course went and I did have to try it just to see if the hype was real, and it is. But this is a place where she is known and is a regular and is connected. I wanted to have you, using that context, just talk a little bit about what does inclusion look like in everyday settings, and what does it look like when it's working?
Yeah, so definitely Banh Mi is a place that she used to see go there all the time for the comfort food, right? For sure. Food is good for sure, right? But I think one of the thing that this place does work is that they make how she feel the moment she walk into the door, right? When she walk in, they don't look past her, they don't look at me, they look at her and they can communicate directly to her. They don't rush her at all. They just have a patient to wait for her so that she can put in the order, right? They just don't assume whatever she need, but they wait for that to be there. And of course, you can see right on my daughter's face then, because at that time, I realized that she is seen there. She belong there, right? And that to me, what inclusion look like and feel like. And it can be, not just at the restaurant, it can be anywhere, right? In the classroom, in the office or grocery store, any workplace. So any place that someone like Tiny walking in, someone there choose to see these individual at who they are and trying to really build that relationship so that when people get enough time, take enough time to understand the preference, understand how these individuals communicate. That is inclusion. It doesn't take a big thing. It's really small, right? It can be very small, familiar routine. It can be welcoming faces. It could be somebody walking, talking directly to her, right? Again, inclusion is not a program. It's a daily choice. It's whether or not Tiny can walk in any places, not just her favorite places, and she feels seen, she feels heard, and she feels like she belongs there, right? That could be the places where inclusion is real.
Love it. I love it. What I also love about that is your consumers and your customers. And so one of the things is that those places where inclusion is happening, where Tiny is seen, Tiny's spending her money. And I just think there is that's kind of I think a crux of this too is it makes a lot of sense. There are folks who are willing to be consumers and participants, and I think businesses being open to that I think is great. And I love how you kind of it's not a program. It's that kind of daily decision. I really appreciate that. Okay, that's great. Um, I'm looking at our timing here. Amazingly, not surprisingly, we've I think had a good sort of robust conversation and hit a lot of points. I know as well that there are questions that have been coming up, requests for resources, and so I know we're going to get those posted either in the chat, but we'll make sure to send those and make those available to folks as well. But to wrap up our conversation with the panelists, I'd like each of you to talk a little bit about, what gives you hope about the future of communication and communication access. I'll start with Mary.
Oh, I'm super excited about the AI stuff. I mean, it is very cool, and I think it can make communication faster and empower independence. So the AI tools that are coming out now are just, oh, I just can't wait to start using them with everyone.
Awesome. Thank you. Michael?
I mean, really just the progression that I've seen from when I was a child with Caitlin, when we're using pictos on a metal ring that are laminated um and now we have iPads everywhere with touch screens and downloadable communication programs with people, patients having their own settings. They can log in and just, on any device. And now with translation services, certainly through AI, how we can use, we can use that to bridge so many barriers that seemed really um, to be completely overwhelming just maybe half a decade ago. I think is incredible.
Thank you. On?
Yeah, I think for me, my hope is still my daughter. Amazingly to see how she communicate her need, her want, and she's starting to do some self-advocate out there in the public forum. Just recently, we both starting to write some poems, and just last month, she reciting her poem at the Amazing event, and just the pride on her face on the stage, it just melts my heart, right? And that's something that I don't know that could happen. So I hope that every child who is non-speaking in the future could be able to communicate, not just normally communicate, but could be able to recite poem just like Tiny and be able to speak up and speak out, right? And of course, I know that this is not an easy journey for sure. I have to fight all along in all different settings, including the places where they should be taking care of my daughter. But
Yes.
it's still really hard, especially now as you get older. A lot of that juggling, a lot of that assumption still happen because she just communicate differently. Right, but I do see change. Yeah, again, Mary and Michael already mentioned about technology. It's advancing for sure. And one thing I think it could be more personal is that I'm working on building the voice bank so that her voice is not computerized like currently, but it could be
Yeah.
more in terms of her natural voice from Asian perspective and Vietnamese perspective. So that is I really hope to have. And
Mm.
also for sure, because bilingualism is really key for me, myself, and my family. And I know for sure for many other families who, right, are diverse countries. So bilingualism, AAC, is to go and is, will open up so many for many other individual who need that, right? So I think the thing that I really hope is that little by little, the more we do this awareness, the more individuals can be able to communicate and they don't have to fight for their voice anymore. But that is the communication right that the word out there when they're ready to hear this void, right? So we want to see that word to be open up for many of these individuals, not for these individuals to fit in the word, but for the whole word to open up for our individual who need that. That's what I hope for the future.
Thank you. Thank you all. And thanks, folks, for participating. You know, I'll kind of wrap us up. This conversation gives me great hope and a lot of optimism. When I think about the Guild's journey, we are on a journey of we provide direct supports to adults and youth. And one of the things that we want to do is also kind of help contribute to the voice of advocacy. And so by doing this film, by having this panel, that's our step in that journey. There's a lot more for us to continue to consider and work on. Today, we had a panel with folks who use their voices to speak and who are coming from different perspectives. And so we want to make sure as we are continuing this conversation that we're bringing in folks who use AAC and finding ways that we're bridging that communication. So we are on that journey as well. And as anyone who has ideas about how we can keep pursuing that, we're excited to continue that conversation. We had an in-person premiere for our documentary in February, and in that moment, we ended with a call to action. And the call to action that we reviewed came out in this panel, but I just want to take kind of close this time together, just reviewing those three action items, and I kind of want us all to have a challenge, a little bit of what will you or what will each of us do differently tomorrow? What will we take away from this in our own life? It's a daily decision, as Owen said. We don't need training. In what ways are we going to stop and be intentional with our communication? And so as you think about that, there's three things that we want you to think about. We want you to think about pause and wait, really allow time for folks to communicate. We want to presume competence, so expect intelligence and intention, and also advocate for access. So ask that question, how can we make communication easier here? How can we remove barriers? Those are three things for us to be thinking about. If you jumped on for this hour, I know that you are interested and you want to pursue this. So I hope you will think about these three action items. I hope you will take some time to learn more, look at the resources, and thank you all for the folks who jumped on and registered. To Michael, Owen, and Mary, thank you so much for jumping on this panel. Really appreciate the conversation and learned a lot. So, thank you all.
Thank you.
Thanks, everyone.
Thanks for
Thanks.
having us. Thank you. Have a good night.